to order. This is, of course, the County Council Health and Human Services Committee. And today we are going to be receiving a very important update regarding programs that have been on the front lines addressing the needs of our residents through the pandemic, and acknowledge that many of the disparities that existed in public health prior to the pandemic have been exacerbated since then. So this will be an important opportunity for representatives from Montgomery Cares, Care for Kids, and our county dental program to update us on what they are seeing on the ground, how they are working to address some of the issues unique to the pandemic and those issues that existed prior to the pandemic. And I do want to just begin by acknowledging and thanking our frontline medical personnel. They have been working literally around the clock, putting themselves at risk, putting their families at risk to keep us all safe. And I think that one of the silver linings of the pandemic is that it has given us an opportunity to see with a new light and express a deep appreciation for the sacrifices of our frontline medical personnel. And I can't thank all of you enough. Joining us today during this session will be Dr. Raymond Crowell, our Director of the Department of Health and Human Services, Dr. Travis Gales, our County Health Officer and Chief of DHHS Public Health Services, Dr. Christopher Rogers, Senior Administrator with DHHS Healthcare for the Uninsured, Dr. Tricia Boyce, Manager of the County Dental Program, Leslie Graham, the Chief Executive Officer of the Primary Care Coalition. And I want to also acknowledge the incredible work of the Primary Care Coalition, who, in addition to continuing to administer and provide critical care, has also been working aggressively behind the scenes to build and sustain an infrastructure that has been quite impressive and that I believe will help lay the foundation for even more improved care moving forward. We also are going to be joined by Ms. Rosemary Botchway, the Senior Montgomery Cares Administrator. So I believe that I don't see Dr. Crowell. Is Dr. Crowell on? I don't see Dr. Crowell. And so what we will do is turn it over to Dr. Travis Gales to make some opening comments. And I believe he has a PowerPoint presentation that he will share with us. We also have a wonderful packet, once again, put together by our incredible colleague, Linda McMillan, and that will go through some specific policy points that we want to touch on through this morning. And Linda, why don't I actually turn it over to you to further set the stage for this discussion and make some opening comments as well. Linda?
Yes, so you've been getting some updates regularly from Dr. Gales when you meet with him on Tuesdays and have your calls on Friday, but you haven't really had a chance in the last several months to have the time to go more in depth on the challenges faced by the public health programs, how they've responded, and some of the issues before them. And so Dr. Gales does have a presentation that he will go through, which touches on many of the issues that are outlined in the memo. Also in the memo are 2 letters that you've received, and one very recently, one in July, from the Primary Care Coalition, the Healthcare Leadership Council, and the Montgomery Cares Advisory Board with some issues that they raised. And so those are also raised in the memo, and we can discuss those after Dr. Gales gives his presentation.
Wonderful. Thank you, Ms. McMillan. And Dr. Gales, thanks again to you and your team. There's no rest for the weary, and you guys have been doing an outstanding job on so many different levels. And I just want to express my deep appreciation to you personally for all of your dedication. So Dr. Gales, without further ado, the floor is yours.
Good morning, everyone, and always a pleasure to be with you all. And it's interesting, we can talk about things. We will talk some about COVID and certainly talk about how COVID has impacted all of these different areas. But it's nice to be able to have substantive discussion about so many of the other important topics and issues that even in the face of a pandemic, we've continued to execute and operate and move business business forward as usual with some slight changes and outside influences. And thank you all for your leadership and your support throughout the pandemic and even before the pandemic, particularly as it relates to all these important public health issues. Now, I do have a fairly extensive PowerPoint. I will go through it quickly. So rest assured, we will get through it quickly. Don't be intimidated by the number of slides, and save room for opportunity to answer some of the salient questions that you all have proposed and Linda has shared with us in terms of preparation for today. So Linda, I shared the slides with Linda. Are you able to put them on the screen, or do I need to share my screen? How does that work exactly?
Let me see what our IT people would prefer.
Okay.
Dr. Gales, you can feel free to drive, and if there are any issues, I'm happy to drive myself.
Okay. So do you have the slides available, or should I just pull them up myself?
I do have the slides available.
Okay. I'm ready to start.
I'm more than happy to share.
Okay. Sure.
Okay, no, please begin.
Okay. Feel free to share, and I'll just click and move. Okay, there we go. Perfect. All right. So first, I wanted to introduce a couple of folks. Before we do that, as the council chairman pointed out, would like to say, take advantage of this opportunity to say thank you to everyone who's been a part of the public health response, public health services, DHHS, our community partners across different agencies, nonprofits, and other entities. We are not able to do this work without a collective effort. And then a big thank you to the residents of the county who have stuck by us and have been patient and have followed the guidelines and all the things that we've asked them to do and continue to ask them to do to stay safe. Now, I do want to introduce, I don't think we've had an opportunity to come together as a subcommittee. Dr. Rogers joined us and is our new Chief Policy Officer and has been working, providing senior leadership to a lot of the groups that are here and working very closely with Tara Clemens, who continues to be a stalwart in terms of working with Montgomery Cares, Care for Kids, MPP, and those programs. Also to Dr. Boyce, I think she joined us for one of our first meetings last year, and so she's familiar to you all, but continues to provide great leadership in the dental program. And also to all of the other senior leaders and managers of all the other programs listed here that we'll provide a brief update with. And can't also go without saying thank you to Dr. Deputy Health Officer Bridgers, Dr. Bridgers, who has been the right-hand man as part of our response and continued efforts keeping things moving. Next slide. So also wanted to make you aware of, we have, in addition to all of the other specific projects we've been working on, we did go through and look at our org chart and think of ways that we could restructure it to be more efficient in terms of aligning the work that we're doing, also creating shared space with shared programs that we're doing similar work. For example, we brought together all of our different programs that are focused on children's health and health for pregnant and expectant mothers and postpartum care. And we've created a maternal and child health bureau that now aligns all of those programs from our area health centers to the work that we're doing in the ACCU DACT area that formerly were apart in different branches. So we've collapsed them into one unit. We've also taken all of our population health-based programs that look at, including Healthy Montgomery, our programs looking at different cancer screening programs. We've combined all of our screening programs into one unit and have put all of our population health programs together within a new service area. And this also includes what historically has been our services for the uninsured and underserved, including Montgomery Cares and Care for Kids. They are all now within one division, which and senior leadership for that division is provided by Dr. Rogers. So just wanted to provide you an update on that. Next slide, please. So some of the challenges that we faced really briefly, this may sound like a broken record because we said this last year and we said it the year before, and this will continue to be a theme, I'm pretty sure, over the next couple of years, is there have been significant cuts to some of our grant funded programs, particularly including our cancer screening programs, which have been cut significantly from the state as influenced by the allotment of funds that they receive from the federal level. We have had to cut some positions related to that. But to offset some of that to some degree, this is why our restructuring of our org chart has helped to provide additional support from an administrative level for some of those programs. And we've been able to absorb some of those positions and repurpose them to other pieces where we do have funding throughout the org chart. We know also and expect that there will be continued cuts to our other areas such as TB and sexual health programs, and we continue to respond nimbly to that to provide and keep those services that we have. Another area is integration of new technology. In an uncertain setting, we're going to talk about telehealth. That's something that we have been working on, particularly in our school health area. For example, from our conversation last year, we've been forced to accelerate some of those thoughts and programs due to the pandemic. And in spite of the challenges faced with that, I think overall the systems have performed well as can be expected in time to be able to continue to provide services to our constituents. And this creates an opportunity to look at, one, how we fund it, how we continue to support it, and what are the best platforms to deliver those types of services. Another challenge is in terms of workforce capacity. The pandemic has created a new workforce environment where we do have a lot of folks who are not working in the offices in a traditional sense. And we're pretty confident that as we move forward in a post-COVID world or even a later COVID world, is that our workforce and workplace will look different. And so we're going to have to respond to potential retirements secondary to health concerns or retirements due to time in the system, and be able to address those potential vacancies and be able to continue to recruit a vibrant workforce who has the skill set to do the work that we need and the experience to do so as well. And there's this thing called COVID-19, which has been a big challenge for everybody to respond to. That's changed the way we do business, changed the way we think about things, and will continue to influence how we move forward. Next slide. So we spent a lot of time talking about COVID. We spent a lot of time talking about COVID over the last 7.5 months. So I won't spend a large amount of time talking about this. But we'll talk about how this has influenced a lot of the different areas as we move forward. I would like to highlight, we had our press briefing yesterday, and we had our council briefing on Tuesday, and we'll talk again on tomorrow. But some updates from where we last spoke is today, for example, there's a joint statement that is coming out from all of the health officers across the National Capital Region, calling on any of our residents who are affiliated with the White House or within that sphere who potentially have been exposed to COVID-19, encouraging them to get tested so that we can do the necessary contact tracing and follow-up to get a full sense of what the true scope of cases are. And because we want to actually find out more information than we've received so far, and we want to make sure that our constituents and residents know that we as a county and all of the counties across the region have services available to help address your questions and provide you with guidance in terms of what you need to do in terms of getting tested or necessary steps for quarantine to keep yourself safe as well as your family. We have seen our testing numbers increase from a government apparatus standpoint with the different initiatives that have stepped up to the plate, as well as increasing testing at the county venues. Yesterday, we tested over 1,200 folks as a part of all of those different apparatuses. Earlier this week, we had another day where we tested over 1,000 individuals, and we have an anticipated capacity today of over 1,300 folks. We're continuing to work and devise strategies to increase after-hours testing as well as testing on the weekends to make it as more accessible as accessible as we can to populations to get the testing that they need. And again, we are excited about all of the different initiatives and our community partners. And I know a Salud is one of them. I think I butchered the name of the project, but has provided a significant source of community testing, particularly in our Latino community, that has been hit really hard. Based upon new cases, and we're continuing to work with our partners in the African American Health Program to address testing and outreach needs within that respective community. Next slide. One of the popular questions that we get asked, and we continue to get asked, is when are we moving to a new phase and what metrics we're using? We've consistently used the same metrics from the very beginning. This is our curve here in Montgomery County for our cases. Some folks have said, well, you flattened the curve. Why aren't we moving forward? It's interesting because we have plateaued to some degree, and it has not gone back up like it was in April and May, but we haven't seen a higher decrease in cases and a sustained decrease in cases that gets us to a level of moderate transmission. The reason why we continue to preach getting the numbers down lower is we know that if we can lower community transmission as much as possible, we decrease the likelihood that someone is going to enter a school, a business, a gym, a whatever type of facility, bringing COVID-19 into that space. And so we want to continue to do what we can to drive those numbers down so that all of the safety precautions and measures that have been put into place, whether we're talking about schools or businesses, can be even more effective in terms of mitigating transmission of the virus. We still have a higher daily caseload. It's a little bit higher than where we were when we made the decision to move to phase 2. And so I fundamentally, from an epidemiology standpoint, question moving to a different phase that increases opportunities, increases capacity, and increases potential networks of transmission when we're at a higher level than when we were when we chose to move to a more restrictive framework. So we'll continue to refine our message and be able to share more data with the public so that they get a consistent sense of what we're doing. But again, we've kept the same message, used the same metrics, including test positivity, daily cases, and cases per 100,000 residents. Next slide, please. Well, I'm going to go quickly through this. This is just a list of the different accomplishments of our public health emergency preparedness team, who has been essential to our public health response. They stood up our incident command center back in March when we received our first cases. They have greatly expanded the Medical Reserve Corps volunteering system within the county. The Medical Reserve Corps has been a critical part of our response, whether it's staffing in the command center, working at our test sites, or providing additional support in other areas of the response. They've continued to work mightily. So all of the testing that we've talked about, they have been critical and vital part of setting up those testing opportunities and strategies, and are extremely critical and an essential component of our continued flu vaccine response, as well as designing our COVID vaccine dissemination plan in the future. Next slide. So mentioning flu shots, get your flu shot. If you haven't received your flu shot, get your flu shot today. And if you do get it, when you get it, feel free to take a picture and tweet it out to you, or you're included in your social networks to encourage those around you to get your flu shot. It's important this year because we want to make sure as many folks as we can have coverage for the flu, because flu symptoms are very similar to COVID symptoms. And from a reporting perspective, particularly where we're talking about schools and businesses, they have a responsibility to report COVID illnesses as well as COVID-like illnesses. And so when the symptoms are very similar, that would potentially cause chaos, because we've got to provide quarantine advice until that COVID-like illness is confirmed to not be COVID. We also know that if we can improve the potential burden of flu in our community, that will also remove barriers and alleviate some of the potential drain on our healthcare system should we need those resources to respond to the a potential increase in COVID cases. Here are a couple of our flu clinics that are scheduled so far. We've been doing flu shots at the Dennis Avenue Center and the Germantown Health Center. We do have some larger flu clinics scheduled, one at USG, as well as the White Oak Rec Center later in the month. We also are looking at other venues to schedule and partner with our testing and food distribution sites. And we're hoping that as we use our allotments, we'll continue to get restocked from the state so that we increase opportunities for folks to get access to it who may not have access through other networks such as their healthcare provider. Next slide. Just want to also give you a brief update in terms of how the COVID vaccine will be distributed. Again, we don't have a candidate yet. We're planning in the event that we get a candidate or candidates, but the National Academies of Medicine have put together some early thoughts in terms of what that would look like, particularly around the distribution plan. They've released a schematic of 4 phases for distribution. Here are the phases that are being talked about in terms of prioritization. You look at phase 1, it's focused on high-risk health workers, first responders, folks who have significant comorbid conditions. And as you move through the phases, for example, the general public who doesn't qualify for those other phases would receive the vaccine, or the vaccine would be available to them in phase 4. Yet it's thought at this point that it will be a 2-dose vaccine. The first dose and getting the second dose approximately a month later. But again, this is planning in the background. We don't know what our candidate will be at this point. So as we continue to move forward, we are building a plan to respond to it and disseminate it. And as we continue to get more details, we will update that. We are building a state response, a local response, as well as working with our partners, the National Capital Region, to build a regional response in terms of a vaccine availability network. Next slide. So just to run quickly through some of the different components of public health in terms of updates, our surveillance and epidemiology team has been critical, a component to providing support to our public health response. Councilmember Albornoz talked about disparities in access and those kinds of things. We have our health equity report that we put out last year and the beginning of the year. We do have an updated health report that we have been sitting on a little bit to try to get more information on COVID, but Dr. Liu is working on that, and we hope to put that out by the end of the year. Next slide. And here are some of the other data activities that they've been working on. 2 that I want to call out is the Healthy Montgomery Community Health Needs Assessment. That process has started with our partners, our hospital partners, as well as our community partners that are part of the Healthy Montgomery process. As you know, we used to do this every 3 years. We've moved this to every 5 years. We will be working with WestStat to do the first health survey, to implement the county's first health survey. And the other great opportunity, it's less surveillance, but falls into our population health category, is we received grant funding from CHRC related to diabetes. And we're building a system that basically looks at creating support services for chronic disease management to keep people from going into the emergency room and getting them effectively linked to primary care services to have tighter control for their diabetes symptoms and ultimately have improvements in their health outcomes. Next slide. Maternal child health, just to give you some updates, again, we've created a maternal child health bureau that now brings together all of the different components within public health services who work on maternal and child health issues, particularly related to our prenatal care program. As you recall, a couple of years ago, it's been about 1.5 years ago now, we received funding for Babies Born Healthy. It's the first time that we were deemed eligible by the state for their criteria. The team has stepped up greatly, and even in the COVID setting, has continued to provide different services. So they're doing virtual telehealth visits via Zoom and FaceTime. They do mom and dad Zoom meetup events every 2 weeks to help build and continue support networks. And here's, again, examples of different programs that they have continued to provide even in the setting of COVID-19. Next slide. Here are just some updates in terms of our other programs that are part of maternal and child health, ACCU DACT, which now is a part of that bureau. They've provided services in the fiscal year of over 2,500 clients. And then our Improving Pregnancy Outcomes program, which oversees particularly focused on the huge disparity that we see in the county and across the nation in terms of infant outcomes by race and maternal morbidity and mortality outcomes as well. And so they've continued to do their work in terms of FEMA and the CAT teams bringing attention to those particular issues and providing those services. Next slide. School health services. As you know, school health services provides a significant amount of services for our Care for Kids program. That has been interrupted due to the COVID pandemic. Public health services and our school health services team are working with MCPS to utilize 2 of our high school wellness centers to basically create hubs, if you will. I know that's been used to describe a lot of the work in HHS and other areas, but to create these hubs that are distributed throughout the county that will allow for us to consolidate services and allow for students to be able to take advantage of those resources. They have been working to implement telehealth services within those sites. And then they'll be able to do these comprehensive different services, including exam. Well, they'll be able to do some of these other services, but the comprehensive services, such as immunizations and physical exams, will need to come into those identified hub areas. Next slide. Licensing and regulatory services, has been, a vital component of our emergency preparedness response. They have conducted technical assistance and support to our nursing homes and healthcare facilities. They continue those efforts, particularly I want to highlight as part of the COVID response, we were the first jurisdiction to stand up strike teams related to nursing homes to help offset, unfortunately, some of the significant issues that nursing homes across the country faced and we faced here within our jurisdiction. They continue to work closely with the state to provide that support. Next slide. Again, they also have been significantly a part of the enforcement around our public health guidance and information for businesses throughout the county to make sure that they are operating safely and to ensure that we're able to keep those provisions in place, but make sure they're adhering to the respective guidelines. And they do much of this work after hours. And so again, special kudos to all those involved. Next slide. So our population health approaches, we're going to talk more specifically about Montgomery Cares and Healthy Montgomery later, but just as a reminder, we adopted a 4-lens strategy over a year ago. The 4-lens strategy is focused on utilizing and looking at social determinants of health and across all of the work we do, equity, access to care, and the use of surveillance and epidemiologic data to drive our decisions and our work. Next slide. And again, just some updates for our programs. I think these are key. Last year when we met, we had just received our initial funding for the Ending the HIV Epidemic Plan. Ending the Epidemic Plan, we were as a reminder, we're one of 48 jurisdictions, or 48 counties, plus DC and Puerto Rico, who were identified as contributing over 50% of new HIV cases each year. We have implemented our plan. We made a great hire in Emily Brown, who started, I think, has been here for a couple of months now, in terms of furthering our plan. We have a community engagement event scheduled next week with our advisory committee, again, to continue the work in that area. The focus areas are on making sure we have 90% of folks who are HIV positive knowing their status, 90% engaged in care and linked to care, 90% who will have achieved undetectable status, and then a 50% reduction in our yearly new cases. Next slide. And disease control, again, important part of our COVID response. But in addition to providing oversight for our contact tracing program and disease control aspects supporting our disease control line, they've also continued to provide support for other reportable issues, and they've investigated just shy of 1,000 cases that are not related to COVID-19 during this pandemic. And you can see the host of other illnesses that are included in that they are responsible for investigating. As I mentioned, the immunization program has worked closely with OMS to provide immunizations for our county staff, and as we mentioned earlier, we'll be providing support to flu clinics throughout the county, as well as providing education and outreach to the community, encouraging them to get vaccinated. And they have been a part of the process of our local dissemination plan. As we've talked about before, we're working closely with some colleagues from GW on coming up with our local needs assessment and capacity assessment, and ultimately what our dissemination plan will be when we get a candidate vaccine. Next slide. TB program continues to move along. The state has reported actually TB cases are down compared to this time last year, and it's not clear if we're just seeing less diagnosis or what the exact cause is, but we have seen a 20% reduction in our cases in Montgomery County. We've had 35 confirmed cases this year, and 7 of which were in September. 8 of those cases are receiving treatment pending their lab confirmation, and there have been 5 interjurisdiction confirmed TB cases requiring interjurisdictional investigations that have been transferred to Montgomery County. Next slide, please. Dental program, I know this is one of the major topic areas for today's discussion, but again, want to applaud Dr. Boyce and Cindy Edwards and their leadership for the team. As you know, the dental program is highly sensitive in a COVID setting, given the nature of the work that they do. And so they have stepped up to put in lots of provisions to ensure that our facilities are safe. Some of the successes that they've seen are listed here. 4 of the 5 dental clinics are open to serve clients at this point, although some may have some limited capacities. We've been able to, Dr. Boyce has recruited a number of dentists in particular areas, particularly pediatric dentists. We now have one providing services 1 day a week. What's also interesting is because of that, we've been able to bring on nitrous oxide, which is a significant component to pediatric care. We've added a second oral surgeon to the staff, and senior clients continue to receive their dentures through the senior denture program. And also they have partnered with immunization to provide dental exams for children receiving their vaccines needed to enter school, as well as created a respiratory fit testing program for their staff members, and supporting other department clinics as well as community clinics. Next slide, please. Some of the challenges is there have had to be significant infrastructure changes to the clinics, such as the installation of HEPA filters, as well as there have been some UV light filters put into place into the HVAC systems. One is in place already at the Rockville campus, and DGS is working on installing those at the other sites. From my understanding, the UV filter will be in place. The HEPA filters are in place already, and DGS is working on those. The UV filter will be in place on October 13th at the Rockville site. It is already in place in Silver Spring, and the team is working on upgrading those to MERV 13 filters to provide a higher level of filtration in the HVAC system. Next, and some of the programs and ideas, for example, the sealant program that the staff has been working on have been delayed due to the pandemic. Also, one of the things that we talked about before is staffing up in terms of making some changes from contract staff to FTE status for our providers. We're continuing to work on that. In the interim, the program has been able to bring in 2 new general dentists who are part-time, an oral surgeon, as I mentioned, who's part-time. We've been able to bring in a hygienist who's full-time, and we do have the pediatric dentist who's part-time 1 day a week. They've also been able to bring in an oral dental consultant who is a part of the University of Maryland faculty, who I believe consults approximately 1 day a week. Next slide. So just want to highlight some of the different Montgomery Cares programs as we close out. Some of the impacts of COVID-19 on the program, significant influence on how we deliver services, particularly shifting from an in-person visit status to more of a telehealth model. Here's just some thoughts on that, and we've got our staff on who'll be able to answer questions as well. Some of the big issues are reimbursement and service delivery. We did approve block payments, and the block payments have been tied to the highest average number of encounters over the last year experience. So we are reimbursing based upon the highest utilization rate for each of the clinics over the last year period. The teams continue to work together, meet on a weekly basis to talk about how to provide additional support to the clinics, both from the county and PCC. When we look at PPE, there's been significant there's approval for expenditure of funds to be used to provide additional support in those areas. And here's a breakdown of how the money has been spent to provide additional PPE support for the clinics. And so there is currently a mix of clinics seeing patients in person as well as through the telehealth model. And we continue to work through what that permanent infrastructure would look like from a telehealth perspective and how to continue that and how to support that both from a leadership and resource perspective as well as how that would continue to be reimbursed as we move forward in the future. Next slide. Here are some updates in terms of the utilization trends. I think it's no surprise we have seen the number of patients hold stable, slightly decreased, and our expenditures have been a little bit down given the COVID pandemic. And this also shows you the number of patients, how we've trended from FY18 to FY20, as well as the number of encounters. And this will be extremely important to think through again as we move forward in a late COVID world and a post-COVID world, which I'm confident that we're going to get to, fingers crossed, we're going to get there in terms of how we modernize and innovate our infrastructure to be able to provide services. Next slide. Oops, go back one. And this is just a similar slide to talk about where we stand in terms of care for kids. And historically, utilization during summer months is low. That's continued this year. The immunization piece is a significant priority. We're working with MCPS so we've got immunization clinics open at Dennis Avenue and our Germantown Health Center site. We are working on standing up the Rocking Horse site again to provide continued services there. We are encouraging parents. There has been a little bit of a lull in parents getting their kids vaccinated or caught up because the belief is, well, they're not technically in school, so they don't need it yet. They can get it before they go back. And so we're encouraging parents to come in and get those done because at some point they will return to school and we want them up to date. And so you can look at our expenditures. We've actually had a higher number of patients this year. We've had over 6,000 compared to 5,500 and 5,500 the 2 years prior, and our expenditures have gone up. And again, as we've talked about before, we are working with MCPS and our school-based health centers to leverage at least 2 of those sites to be able to provide extended services and access to utilize those spaces again for kids who are in the program who have not been able to receive those services with the schools being closed. Next slide. Here is just an update on our maternity partnership program and looking at the numbers where we stand. We did see some dips in enrollment earlier in the pandemic. Those numbers are starting to trend back up, which is great. Again, this also is inclusive of leveraging telehealth and other virtual resources to be able to provide support for those types of visits. So as that technology has improved and our understanding of that technology, we've leveraged that more and seen an increase, or our numbers are starting to go back up in terms of enrollment. Next slide, please. And again, this just looks at our utilization pattern and our trends where we stand. Want to again highlight the work of the team leveraging and utilizing telehealth, particularly as time has moved forward. And again, they've been working closely to use that to increase utilization as evidenced by the previous chart. And so we are following this very closely because we also know that at some point, I want to say in July and August, we were getting reports from our health centers that they were seeing pregnant mothers showing up, particularly Latino pregnant mothers showing up who were COVID positive. And that's something that was also noticed across the country. So we continue to monitor those trends. When we found that out that happened, fortunately, there had already been conversations and partnerships with our health systems and members from the Latino Health Initiative to talk through some of those particular issues. And I know that those conversations and that work continues. Next slide. So that concludes the slide component in terms of updates. I do know that there are some other areas and questions that were provided. This was meant to provide an overview and again, an update of where we stand and to provide some additional context to the conversation. I will stop there. Happy to answer any questions. And as I mentioned, we've got Dr. Rogers, Dr. Bridgers, Tara Clemens, and Dr. Boyce here who are part of our team who provides additional leadership and pretty much the essential leadership on the ground for those respective programs to assist in the conversation. Thank you.
Thank you, Dr. Gales. That was a very comprehensive and impressive presentation. What I'd like to do now is give Ms. Graham the opportunity to make some opening comments, speaking on behalf of PCC, and then go to the packet and specifically page 3, where Ms. McMillan laid out very nicely and succinctly those issues that we can expand upon from the presentation. And obviously, as is always the case, to my colleagues on the committee, if you have a question that you'd like to ask at any point, just text me and I will put you in the queue. So Ms. Graham.
Thank you, Leslie Graham, President and CEO of Primary Care Coalition. I wanted to echo what Dr. Gales has said. The COVID-19 has been unusual experience for all, but we're very grateful for the role that we've been able to play with DHHS and for the cooperation and collaboration with DHHS and what we've been able to do together in the safety net system from last fiscal year being able to bring in so much PPE that will carry the clinics forward through this time, to being able to bring in home monitoring equipment, high blood pressure cuffs, scales, pulse ox, so that telehealth can work by having those who have chronic conditions able to manage their conditions at home utilizing telehealth. So it has been really an excellent partnership. Glad to continue it, and happy to answer questions today as they come up.
Thank you, Ms. Graham. That was actually the perfect segue, because the first item that we would like to expand upon in the packet is telehealth. Obviously, we've made tremendous progress, both on the technology, on figuring out reimbursements, and that is one of the hopefully many silver linings as a result of COVID. And there are a lot of things that telemedicine and telehealth can do. But as we all acknowledge, it will never completely replace in-person care. But can we talk more specifically about what some of the lessons learned have been with telehealth on the positive side, and where we see the possibility of expansion to address some of those disparities in health issues? And then conversely, if we could talk a little bit about some of the challenges and some of the issues with telemedicine and telehealth to level set expectations, as Dr. Gale says often, and I have borrowed that term many times over the last few months, but also acknowledge the opportunities that arise with telemedicine and telehealth. So Dr. Gales, if you want to start, and then Ms. Graham, if you can expand from there, that would be great. And obviously anyone from your team, Dr. Gales, who would like to chime in on this, we'd appreciate it.
I'd be happy to, and then, also happy to, share the floor with Dr. Rogers and Tara in particular, as they have been a part of, working with PCC and others around this issue regularly. We support the permanent inclusion of telehealth within Montgomery Cares, and a telehealth work group was established with the clinics and PCC in September, so just last month. And the group meets on a bi-weekly basis to discuss those challenges and the benefits of the program, best practices, and what that would look like moving forward in the future. So I would given that I would, I think Dr. Rogers is on the call with us, provide the opportunity for him to share more in depth about what that committee has talked about, and to particularly highlight those best practices that we found so far.
Good morning. Thank you, Dr. Gales. We, in collaboration with PCC, we asked PCC to field a survey to really understand the clinic's early experiences with telehealth. And it's consistent with what we see in the literature. It's consistent with previous experiences in standing up telehealth throughout the country prior to COVID-19. For example, it's had an impact positively on social determinants of health. Patients no longer have transportation barriers that they may have had with trying to get to appointments. It has also had a positive impact on no-show rates. Patients are able to access care, to receive the care. They are no longer missing appointments, which is also will ultimately impact, their overall health outcomes. On the clinic side, it's really allowed the clinics to provide safe care. Of course, when COVID-19 started, many providers, the uncertainties around the care, the shortage of PPE throughout the country, it really allowed providers to really more timely and more safely and comfortably able to provide the care to the patients. We also have seen for safety for patients. Patients are also nervous and still are quite afraid to come into the doctor's visits. And so telehealth has allowed patients to feel more comfortable in their homes. And then we also have those patients who feel isolated, lonely patients. And so those patients are also able to receive care as a result of telehealth. So those are some of the early findings that we have gained from talking to the clinics and some of the surveys that we have fielded.
Thank you, Dr. Rogers. And my colleague Craig Rice has a question. We'll get back to you in a second. He's in the queue. But Ms. Graham, if you wanted to expand from PCC's perspective on your experiences with telemedicine and telehealth, that would be great.
Sure. So the Montgomery Cares clinics pivoted to telehealth very quickly upon the beginning of the pandemic, and that was really wonderful to see. I think you've seen some of the data where there was an initial dip, quite a significant dip in visits as the pivot occurred, as patients could understand what was and wasn't available to them. We are seeing a climb back up, as you've seen in some of the other slides that Dr. Gale showed today in visits. I think, as Dr. Rogers said, it does seem to at least maintain or improve no-show rates. Many patients report that it offers them the opportunity to reduce their risk of having to use public transportation. Reduces their risk of or their fear of sort of being out in public if they have fears around their immigration status. And physicians are reporting that they have that the ability to manage chronic illness, pregnancy, as Dr. Gales mentioned with the MPP program, through telehealth is good. I think we want to just clarify, telehealth can be by phone or by video. And there is, we were on a call with Kaiser yesterday, which is going to begin a Mid-Atlantic pilot of assisting federally qualified health centers with improving their use of telehealth. But there is evidence, there is data coming out around the use of phone versus video. And for many of the lower income patients, phone can often be preferred. They may have shame about their backgrounds or lack of privacy in their household situations, or be stepping away from their work site in order to have a visit. So that's a very interesting distinction. I just want to make sure that we're looking at is phone versus visuals. So that's something that we're looking into. Interpretation, some of the products can be difficult to use. Some of the telehealth products can be difficult to use with interpretation and to link in, say, the county language line options. So we need to really be considering that with regard to equity for the population that's served in the Montgomery Cares clinics. Also, the ability to offer to sign consent documents and to provide the filled out documents that are needed for the OESS and eligibility. We need to look into that more. And then the level of technology assistance that clinics are now needing to give to the patients in order to get them onto their telehealth visit. I think somebody labeled that basically the medical assistants become telehealth Sherpas. So those are the sorts of things that are being worked out and discussed in this group. As Dr. Rogers mentioned, we have a telehealth group. So I just wanted to bring those up as sort of detail elements that are being thought of.
Thank you. And I know that the group is also working on establishing a set of guidelines and, as you guys indicated, best practices that we can share with both clinics, but also patients too, sort of the do's and don'ts, and provide a guideline, because it's evolving so quickly, and we're learning as we go on some level. And so I think those guidelines will be helpful, not just to our patients and clinicians here in Montgomery County, but within our region as well, as we've been a leader in so many other spaces. My last question on telehealth before turning it over to Councilmember Rice for questions is, and Councilmember Glass has a question as well, is cost. So a lot of what we are doing is obviously with existing resources, but those are very positive outcomes, even in the short term that you've indicated, that I think are something we can expand upon. But have we begun to quantify what the expenses might be, both in the investment in technology, in the investment in infrastructure within clinical offices to assist and provide IT support to patients, which I assume is challenging right now, or some of those other issues? Will the work group come up with some potential costs that we may want to think about as we prepare for budgets moving forward?
I think the short and long answer are yes. And I know that as we've had some conversations within HHS looking at the different platforms, what would be acceptable, for example, Zoom Health versus Microsoft Teams, and those kind of things. And we've been talking with our council around the privacy provisions within that. So now that I think we have a better understanding of what platforms would be acceptable to be used, I think then that will help guide the conversation around the cost for additional licenses and the other needs from a technical assistance support issue level that would be needed to provide support to the clinics to be able to roll that out successfully.
Thank you. Super helpful. Councilmember Rice. Sorry about that. And you are on mute.
Sorry about that.
Mm-hmm.
So when it comes to the piece around telehealth, and I think back to when my mother had to get some assistance from her doctor and went through telehealth, especially for seniors, navigating the technological space is incredibly difficult. Setting up, trying to get an app if they wanted to do Zoom so that they can have video, but not having the video and then just having over the phone, and ended up going into a conference call. And this all happened when I was away from the house. And so, was told this by my mother as, she tried to navigate how to get through this. My concern is also because we've seen so much of this with our students, with MCPS and the families who are also technologically challenged. We have the digital divide when it comes to access to broadband and high-speed internet. So while telemedicine is good in one sense, it exacerbates some of the problems that we have when it comes to the digital divide, technological access, as well as technological savviness. And so what has been the kind of lay of the land? What have you seen when it comes to these kinds of things? And what are you hearing from folks? And what are some of the solutions that we can help work with you in terms of how to address that?
Would you like me to answer that? Or?
Whomever.
So yes, and we see, as you're saying, in the seniors population, there can be technological challenges, but similarly in a low-income population that might have prepaid phones, many things are, many of the technological options are for those who might be working off of a laptop. and many of the patients have lower end phones or certainly don't have iPhones, might have Android-based phones or other phones. So we've got a lot of technological challenges, and that's part of the selection, is having to figure out which platforms can meet the needs of this particular population. There are many good platforms out there, and some may be a wonderful platform for a private medical office, and some may be a much better platform for this office, for this type of population. I think the number of clicks is important. We know this is true no matter in what kind of technology. The more things people need to click through, the less that they will continue on. And then I also think that one of the things that needs to be looked at is long-term. What will be the support through county resources, and what will the clinics need to take on as their own support? When we think about the sustainability of telehealth, it's not going to go away. And like I said, we can look at, there are some things that really need to be done through a video hookup. There are some things that must be done in person, and there are some things that could be done just by phone. So there are different ways to use technology. And in the end, I think what we need to find is what is going to be the least barriers for patients, that they will do whatever is needed. In this population, people will figure out how to load WhatsApp and work with WhatsApp so they can communicate with their family in their home country. But they've got a high incentive to do that. We need to make sure we pick something that has the right incentives and the lowest barrier so that people will utilize it. And secondarily, something that has the right financial incentives, both financial in terms of payment, but also the structure needed within a clinic to be sustained as a business line or a service within the clinics themselves. So if it requires significant effort by the medical assistants to be sort of technology Sherpas, how do we make sure that that is of a sustainable, that the rate is being paid that is sustainable? So I think those are the types of questions that you're asking and the kinds of conversations that we need to have.
So my follow-up to that is just in terms of, I know how we also in the school system, and I know this happens in the community, become disconnected. And so my concern it also is, was there any outreach done to former patients to say, we're moving to this new model, please keep in contact with us via X, so that they knew that if they typically showed up and, went through this model, they would, be able to get an appointment, talk to someone, whatever the case would be. Understanding that a lot of people aren't as comfortable utilizing technology to talk. I mean, again, I'm putting my mother on the spot here, but she's one who first face-to-face contact with folks and all of that, and doesn't like to digitally email somebody or send someone a text. It's, I need to talk to someone to ensure that they understand what's going on. Was there any of that outreach done to our current clients to say, this is a model we're moving towards, and this is how you're going to now need to keep in contact with us?
I'm going to turn that over to Elizabeth, who's been doing our Director of Provider Services, who's been doing some surveys with the clinics on that. Elizabeth, are you? Oh, you're on mute. All right. Well, I think that, let me just give a quick answer for that. So we've done some surveys with the clinics on the use of telehealth. Many of them have been proactive in reaching out to their patients who have chronic illnesses to ensure that they are being served and that they understand that they can be served by telehealth, or understand when and why they need to come in person, so that they can have that distinction.
So, Councilman Rice, that's a great questions, and these are questions that myself and Tara have been asking within our telehealth work group that we have with PCC and also the clinic, so that we can better understand a lot of these patient-provider relationship issues, patient experience issues. I want to show you that any DHHS policy, telehealth infrastructure will ensure that these issues are being addressed, and how we provide patient education how the providers are established in that patient-provider relationship with the patient, how they are following up with patients post-care. And so as we continue to gather this data from the survey, we're going to make sure that these kind of requirements are laid out in our telehealth infrastructure or policy.
That's excellent. And I really appreciate that, because I know that, look, we can do all we can and still will have folks who will fall off the grid. And so I just want to make sure that we're doing all we can to keep them on and understanding, regardless of what it is we do. You guys have been doing this a lot longer than I have. What will happen if we don't, right? And so from that perspective, that's why it's really, really important, especially because it's so easy now to get lost, right? Before it was a lot harder because, you know, you're still around, people still see you, interact with you, but now it's real easy to get lost. And so from that perspective, it's always a concern. And so I really appreciate you guys taking a look at the data, talking to folks, discussing this in the work group. And again, as the chair said, please let us know how we can help and assist in this. If it means the county partnering with PCC and with others and with the clinics to mount a campaign in terms of reaching out to folks and just, a public awareness campaign about what's going on. We're more than happy to do that. We've done that for a number of things, including our requirement to wear masks. And so we're more than happy to do that when it comes to this as well, because it's incredibly important. And last but not least, thank you for all of your great work when it comes to this. Again, it is absolutely phenomenal to take it to this next level. I know myself, you guys reminded me that I need to schedule my physical. So I'm actually online doing that, my e-physical. Yeah, so good. Shout out to all of my, again, I'm just going to say this because I know that we're one of the ones who don't do it. To all of my Black men out there, go get your physical, go get checked, make sure that it's not just about COVID. It's about making sure that you are understanding your health. And just because you might feel as though you're good because you're in the gym or you think you're fine, it doesn't mean that you're always fine. It's still always good to have that checkup. So anyway, I'm doing that as we speak on the side.
Thank you, Councilmember Rice. And on a lighter note, I think your mom and my mom have a lot in common. So I'm going to turn it over to Councilmember Glass.
Thank you, Mr. Chair, and I'll make this brief because Councilmember Rice asked all the questions I was going to ask. Trying to drill down on the dynamics of how telehealth and telemedicine are working, particularly looking at it through an equitable lens, knowing the communities that PCC is serving and DHHS and the conversation we're having today, right? Wanting to make sure that we have fair and equitable medical opportunities for those to be safe here in the county. And I particularly appreciated Councilmember Rice in comparing this type of these opportunities for healthcare and equating it to MCPS and remote learning, because it's exactly the same. And we just want to make sure everybody understands how to get that access and not only connecting with the service providers, but connecting online. And so I think it was Dr. Rogers, I think you were saying that you're going to get some more information from the providers, and I'd love to drill down on that more and really see how people are connecting and how we can help them stay healthy through the incredible work that all of you are doing. And I know we have more in the packet, so I'll stop there and turn it back over to the chair.
Thank you, Council Member. And in my family, we've had 3 pediatric virtual visits since the beginning of the pandemic. All were incredibly successful, 2 done by phone and 1 done virtually. So this has been a great discussion. I think we'd like to follow up on this to check the progress of the committee. And if there are any reports formally that come out of the committee that are written, would love to track those. I am curious as to, as we figure out the limitations of telemedicine and telehealth, the implications for dental clinics, the implications on what can and can't be done in terms of, what's needed, and then the follow-up necessary. All of those are things that are being covered right now as we speak within this committee. So that would be great. I want to move on to the next item in the discussion, which is specifically on block payments. And I know Dr. Crowell is not here. And so I'm not sure if Dr. Gales, you're in a position to be able to respond to this question, but the packet says, how is DHHS determining whether to continue a block payment, return to the previous system, or payment per encounter, or structure a hybrid that could include a base payment, and how, and also, is that payment based on clinic visits? Obviously, funding has become a huge challenge, so I'm not sure if you're in a position to respond to this or provide comment, but would love to hear those comments if you can.
Sure, I can provide some insights in terms of how kind of history and in terms of how things are funded. During the the pandemic, I'd love to say the past pandemic, but the emergency still is going on. The clinics have been reimbursed through the block payment schedule, as you mentioned, and this was implemented to help reinforce clinical financial stability. The clinics have been able to see clients for an unlimited number of visits, thus not having to adhere to the 2-visit rule that has been in place historically. Each payment is equal to the average of the individual clinic's highest 3 monthly payments in fiscal year 2020 to date at the time. So from July 2019 to February 2020, earlier this year. For FY21, during the health emergency, clinics agreed to the same monthly rate established in March 2020. Now, as we currently stand, after COVID-19 ends or the emergency is lifted, the plan is to go back to reimbursement per encounter. While the current block payment structure has limitations, given the clinic may have higher utilization than agreed upon reimbursement rate, we are exploring, as you mentioned, the optimal payment reimbursement structure for the future. So I think it creates the opportunity to have ongoing conversations about what that would look like. I think we're still trying to figure that out, because on top of all this is the block payment system is not how the program, historically has been run. And so this is much like the conversation around telehealth that we had in terms of finding out best practices or things that work that could be done differently. We're in a very similar situation. So with that historical perspective in place, I think, this, again, there will be ongoing conversations about how to optimize and support the clinics, as well as come up with a fiscally responsible payment system that, again, maximizes client opportunity and maximizes quality of care, but also is respectful of the budget constraints.
I appreciate that response, and obviously budgets are going to be very compromised and challenged as we get into the recession, and we're all bracing ourselves for what's going to happen with the Affordable Care Act and the possible turnover in the Supreme Court. So, the issue of reimbursement at all levels is a significant one, and while the county is much more well-positioned than most other jurisdictions, it's distressing to anticipate what's on the horizon. So I appreciate that response. All right, the next item is specifically regarding
Councilmember Rice.
Yeah.
Oh, sorry about that. Go ahead, Councilmember.
No, that's all right. Just very quickly. Both Councilmember Glass and I serve on the National Association of Counties, excuse me, and I'm on the Human Services and Education Committee. And so I really am curious as to whether or not there's been talk at the national space. And Dr. Gales, I know that you have some links to some of those spaces. Has there been talk about additional funds, understanding that, again, these are our most at-risk populations, not just from contracting COVID, but also in terms of rolling out a vaccine, and how that communication will need to be there for especially these communities that we're serving, our communities that are a part of our Montgomery Cares community. And so has there been any talk about nationally funds flowing to states and to localities to help educate our public about the vaccine? I know you had talked about that at the beginning, but has there been talk about that part of it in terms of marketing this and getting this out to those communities, understanding that they're identified as the ones we want to prioritize, but what's the plan for how to get to them?
Well, unfortunately, and I hope this is not taken as a political or editorial comment and just as a factual depiction of where currently things stand. There hasn't been much conversation, I think, on a national level, at least coming from the federal branch, in terms of some of the things that you talked about. Now, we've talked about that at a state level with conversations with other health officers from across Maryland and with our colleagues at MDH. And we have engaged in those initial conversations on a county level to talk about how, or to underscore the importance of just what you talked about in terms of, we can have a great dissemination plan for a vaccine, but if 50% of people are still saying, I'm not going to get it and I don't trust it, it's important to do that work up front now to provide that outreach and education so that folks, when we do have a candidate vaccine or vaccines in place, that, we will have worked to address those concerns. And we know that, unfortunately, when it comes to, science like this, there are a higher level of concerns in communities of color, rightfully so, in terms of historical perspectives within public health, as well as the fact that we don't always see the best representation or diverse representation of communities within vaccine trials and things like that. Now, one thing that I want to highlight is, our colleagues at GW are participating in the national trials related to vaccines, and they have been tremendous. They've actually overperformed in many ways in terms of having diverse representation in their clinical trial site. And we know that there are a number of other places that are in the same situation. So we're working, we've actually engaged everyone from our Chief Equity Officer, Tiffany Ward, in the conversation, and we'll be including our health initiatives and program within that as well to talk about how to address that message. Now, the other component to your point and Councilmember Albornoz's point is we are holding our collective breaths in terms of what healthcare will look like, dependent upon Supreme Court decisions and dependent upon the national election. And we're going to probably, healthcare as we know it now will look different, come late November and potentially in January. And so we have to continue to look at ways, to do the work that we're doing, expand services as best as we can, and also be as innovative as we can. We also know, the last thing I'll say is, we also know that there are other policies that aren't necessarily health related that influence individuals' willingness to access services. So, as we continue to talk about immigration conversations and those kinds of things, we know that those types of conversations and policies also significantly impact an individual's willingness to utilize government resources in terms of trusting those resources, but also stepping up to feel that they're safe to do so. So we're all holding our breaths to see what things will look like in 6 weeks and potentially in 3 months. And I think, again, once those dominoes begin to fall, that will also help inform some of these very same conversations in terms of the directions that we will move forward.
So, Mr. Chair, I'd like to just put a pin in this one, because when it comes to the financial viability, which got me thinking about this whole concept about federal and state support, but the financial viability of our clinics is heavily dependent upon a structure that continues to support. And if that, and I see you're smiling because you know exactly where I'm going. We're going to have to come back to this and take another look come November as to what the landscape may look like in terms of the efficacy of our clinics. Because quite honestly, and Dr. Gales, one of the things that you highlighted when it comes to our stance on immigration policy and what it is that we're going to do there, I mean, we're basically saying to our immigrant community that, you might as well not even step up anywhere close to anything that's affiliated with government. And this isn't a political statement. This is just what, the stance of the administration has been. And so that's just a statement of fact, right? So again, it's one of those where it just is going to require us to do a bit more to figure out ways in which we can help folks to ensure that they're still connected to these vital services. So thank you, Mr. Chair. Appreciate it, sir.
Well, it's funny you say that because I had an epiphany the other day of a health initiative fund because we need to think very much outside the box, which will likely require a dedicated funding source. This is not ready for prime time. We have just begun to think about this, but I will include my colleagues on the HHS committee in these conversations. because we do need to brace ourselves for the inevitable in the short term. And gosh, as if Joe and Kamala didn't have enough pressure on them, there's a lot going on and a lot on the line in this election. Moving on to the next item in the packet for discussion is the eligibility process. And I know, Dr. Gales, you and your team, I so appreciate this, have worked diligently to be able to better leverage county resources so that if patients or residents were eligible for federal programs or state programs, we made sure we didn't leave any money on the table so that we could maximize the precious resources that we have here in the county. But as is always the case, when you transition to a program like that, there are lessons learned. If you could give us an update on where we are with that transition of eligibility determination to the Office of Eligibility and Support Services, and how that's going and some of the lessons learned, that'd be great.
Sure. Actually, I'll just make some initial comments and then again open the floor for Dr. Rogers and Tara to comment again, as they've worked most closely with our eligibility staff. So, we were a little bit of history. It feels like so long ago, but it was just last year. I think we've all aged about 6 years in the last 7 months. But at any rate, so as you know, we were moving through our eligibility process in phases. We had a phase 1, and then we're moving to phase 2. We froze things in phase 1 and had yet to move forward in phase 2. We had planned to do so earlier this year, and COVID happened, and so pretty much everything froze where it has been. And we've extended the eligibility deadline a number of times, most recently to, I believe, the end of January. Tara and Chris, correct me if I'm wrong on that. But the plan is we don't want to keep indefinitely extending that, because we actually do feel that we have some potential solutions, in part driven by some of the very same concerns that were laid out in this most recent exchange between us, talking about the realities and where we need to go. As well as informed by the need to be innovative and forward thinking to address concerns. So we are working to move those conversations around how we move the program forward. Those conversations kind of stopped as well in February when COVID happened. And included in that will be a continued discussion about the eligibility piece in terms of broadening that, keeping it as it is, and what changes or tweaks needed to be done to the system to support it, even more in terms of resources and infrastructure to move that forward. So that's the general perspective. Again, I would open up to Chris and Tara to comment further around the specific best practices that you asked for, or lessons learned. I won't say everything's a best practice, but the lessons learned so far. Dr. Rogers?
Yes, we couple things. That one is one of the first things that I asked when I joined the department is really about the data, and so I met with MCAB, and I have requested of MCAB, but we have come to an agreement to create some type of data infrastructure work group to really study the data needs in order to better measure and monitor, understand how to really eligibility metrics to really understand patients that may be transitioning to Medicare or Medicaid. And so that work is currently ongoing. I am looking forward to working with MCAB a little bit more closely to really create some type of data plan so that we can better capture the data needed to really understand really all things eligibility and all things eligibility determination. As Dr. Gales mentioned, we have met Dr. Gales, Tara, Dr. Bridges, and Dr. Crowell regarding how to make that transition so that all clinics eligibility has been transitioned to OESS. That conversation is ongoing. As Dr. Gales mentions, COVID has kind of dampened some of those conversations, but we continue to try to move that ball forward. And also, as Dr. Gales mentioned, we have extended eligibility to the end of the year. And because OESS has transitioned to things online, we are currently in conversations with them on how they are providing outreach education to the Montgomery Cares patient population, maternity partnership patient population, healthcare for the uninsured patient population, in order to make sure that they're able to enroll without any particular issues or challenges.
Thank you. The next item is related also with regards to eligibility, and that's specifically the qualified health plan. And I appreciate DHHS postponing the changes in eligibility criteria, and I believe the changes, the transition has been postponed until December 31st, 2020. This causes anxiousness and anxiety as we get close to approaching that date. And I know December 31st, has a nice ring to it because it's the end of the calendar year. But would it make sense for us to explore the feasibility of tying the postponement to when the governor alleviates the emergency clause in the in the state or here in the county? We've done that with the policies related to evictions. We've done that for some other policies just so that organizations and patients can plan for this. And so I wanted to get your thoughts and feedback on the feasibility, whether you think that's a good idea, whether you think it's something worth exploring. And I know, again, Dr. Crowell isn't here, and I'm not sure if you feel comfortable speaking on behalf of the department on this specific issue, Dr. Gales, but if you could comment on any of that, we'd appreciate it.
Well, I think in Dr. Crowell's absence, I think we should just ask for millions of dollars and make lots of requests, and then he'll just have to live with it. But I think that's something that we can continue the conversation around and discuss and look at what makes most sense to do that. And I think, I don't think it's an either or proposition. I think we can, continue to think about that as well as we've talked about, move those conversations forward about how to solve that issue of QHP affordability. I don't think we have to wait until the pandemic's done to, further those conversations about what that system looks like. But, we can glad to have a continued conversation around making those changes to the eligibility timeline.
Appreciate that. And the next two items we've discussed frequently, both here and in many, many other sessions. And I have to say, Dr. Gales, I give you and your team and the procurement staff within the county a lot of credit on being as aggressive as we've been on expanding testing in the county, being creative, working with, scouring literally the world to look at contracts that we can establish with testing companies. And I think the infrastructure that we've established with Por Nuestra Salud y Bienestar is a fantastic model, with the extension of the health promotores, with the bilingual and multicultural services, the additional thought that's been given to even the paperwork that people have to fill out, and the direct interaction that we have in those 4 zip codes in particular that continue to be disproportionately impacted, in our African American community and our Black community, who still continue to die at higher rates than any other community. So I don't have a lot to ask with regards to testing specifically, because I know that we've significantly expanded capacity. I will say that you had mentioned in previous updates that there aren't as many people seeking tests, which is something that we need to keep an eye on, to continue to encourage people, particularly through contact tracing, to receive tests. Any comments that you'd like to provide generally on testing? And then, Ms. Graham, if you could talk about testing from PCC's perspective as well, and which clinics have had more success than others on testing, and what you're seeing in terms of lessons learned.
Well, from a testing perspective, fortunately, we're starting to see an uptick again in terms of folks coming through the doors to get tested.
Good.
I do think that was influenced by, if you recall, several weeks ago, there was some confusion around CDC guidelines saying everyone should get tested, to no, only symptomatic folks should get tested. And there seemed to be some politicization of those guidelines. And CDC came back out a third time to say, actually, no, asymptomatic individuals should get tested too. So I think that that has died down some, and so folks are coming through. So, for example, in looking at this morning's numbers, across the state for the total number of tests that were resulted, we had over 5,700 tests resulted from Montgomery County. And then the reports of the last, 2 of the last 3 days in the county, just from the county testing apparatus, we've had over 1,200 folks tested. So that's an encouraging sign that the numbers, at least within our jurisdiction, are increasing. And again, folks are starting to come back in, and they're trusting the guidance, from the CDC, which is consistent with what we've said all along, is that asymptomatic and symptomatic individuals should get tested. Now, I think that at the same time, that doesn't mean we stop where we're going, and rest on that. We've had, for example, when we've had conversations, with schools and athletics and sports and all those different things, we've talked about the value and potential value of integrating testing within those conversations and routine testing. And so we're continuing to strive, as you mentioned. We're trying to identify new vendors and new technology to be able to make testing a more pleasant experience, as well as a seamless experience in terms of, from from learning about it, to registration, to completion of the test, to getting their results back. And I want to say again, a special kudos to the testing team within Public Health Services, as well as our colleagues from Technology Services across the county, the leadership there, who helped streamline that process and make improvements to the process so that it's more seamless and it's easier for people to walk through and get the results that they need.
Thank you. Ms. Graham?
Sure. So in terms of the Montgomery Cares clinics, some of them are doing symptomatic testing, but it is fewer. Mobile Med is doing symptomatic testing. Mary Center is doing symptomatic testing. Part of many of the clinics have some space constraints to bringing COVID positive patients into their setting. So that's an issue that's being dealt with. We also have 3 of the clinics, Caseman, Proyecto Salud, and Mary Center, are participating in the Por Nuestra Salud y Bienestar program. That is separate than Montgomery Cares. The purpose of that is to have the clinics with their trusted reputations in the community go into the community to assist in offering testing. And the purpose there is much more around finding asymptomatic individuals. And those clinics, they're written into their contract, just to be clear, is that they cannot double bill, of course. If it's a Montgomery Cares patient and they're billing Montgomery Cares, they cannot bill Por Nuestro Salud, and the same, the opposite way. We are currently, with all of the clinics, exploring rapid testing that could be done at point of care. Abbott has a system, McKesson has a system. It's looking that there are funds available to do that, but but is it possible to get a regular flow of those test kits right at the moment and the reagents, and will supplies be continuous? Those rapid tests are fairly new, and a lot of them are going to, at the federal level, are going to governmental entities. So we're exploring that right at the moment and hope to be able to do something on the rapid testing front in the future. Great.
And obviously it goes without saying, if you need any help or assistance, I know that, on any level, please don't hesitate to let us know. The next question is specifically with regards to the flu vaccine. This is pretty straightforward. Are there sufficient numbers of vaccines within our clinics currently, or is there a concern that we're going to run out?
So in terms of flu vaccine, we do typically exceed our flu vaccine budget each year as we order flu vaccines, and FY21, we have already pre-booked the receipt of flu vaccines for a level that is above budget, approximately over 20% above budget. However, we do have monies that can be moved in other places within the budget. And we believe there are some savings on things like printing this year and those types of things. So it is an area that has typically been budget-wise underfunded each year with vaccines, particularly for flu. and it's had a flat budget. So we do believe that we can get the vaccines this year that are needed for the clinics, and that is, of course, depending upon national supply. But we have pre-booked a significant amount, a higher amount of flu vaccine than we have booked in the past.
Dr. Gales, anything to add? Are you concerned at all that we may not have a sufficient dosage of vaccines? Or I know we're in the queue to receive some, but is there any concern that that's going to be an issue?
At this point, I think we're okay. And, the state they've got, we've got to use our allotment that we get, and then, we're getting more because they're watching it carefully. But I think at this time, I'm not concerned. Certainly we'll continue to follow the trends and see where they are. But at this time, I feel okay.
Great. And for the record, I received my flu vaccine 3 weeks ago. So, okay. And then the final question.
Mr. Chair?
Yes, go ahead. Councilmember Rice.
Well, I think Councilmember Glass was first.
Oh, sorry, Councilmember Glass.
Great. Thank you. So, we're talking about telemedicine, telehealth, you can do virtually. Flu vaccines, you can't, right? You got to be present for that. And so a number of people have been contacting me, one asking about the supply that we're going to have. So I appreciate the questions from the chair and the responses that we should feel confident, and our constituents should feel confident that we will have enough supply for them. But as we continue to adapt to this new environment, a number of individuals, particularly seniors, are asking about drive-through possibilities or other ways of administering the flu vaccine and instead of the traditional coming into the office. Are there any considerations to any other types of ways of providing the vaccines to individuals?
Yeah, that's an excellent question. And yes, in fact, the two larger clinics that we've announced, we're hoping to utilize some of that drive-through component to it. It is also why we're looking to try to partner with some of our testing and food distribution sites where people are coming through in that exact setting to be able to leverage that infrastructure that's already in place.
Well, so you've taken it to a level I hadn't even thought of, but it makes perfect sense that if people are receiving services and they're receiving food or something else, that we offer them the opportunity to be healthy to another level as well. Let me, because I'm not quite sure how the concept works. I just know I've been asked about it. How does in theory, a drive-in or drive-up, pull-up, whatever we want to call it, vaccine scenario work?
Well, it actually probably be very similar to how, the drive-through testing comes up, you'd be in a setting, you'd be in
for the COVID, the same kind of situation.
Yeah, same kind of concept. You drive up, there'd be someone, you'd have a conversation, fill out your information form, consent form, that kind of stuff. And then, because it's applied in the arm, and so, ideally, you can reach in and administer. The challenge is we typically ask people to just kind of observe them for a little bit, particularly, with our older population. So, there might be a holding area, if you will, just to kind of make sure that people are okay and they don't have an adverse reaction to it, and then be able to move on.
Good. Okay. Well, I will relay that to those who've written into me. And is there any timeline on when we might expect that type of collaboration?
Not at the moment, but we're working to try to get it out sooner than later. Because like I said, we do have two larger clinics scheduled later in the month. And we're, again, actively working to try to integrate some testing opportunities within the current infrastructure. So I think the best answer I can give you is that we're working on it and we're hoping to get it done sooner than later.
Excellent. Thank you very much.
We did a drive-through at my pediatrician's office, and my kids did it outside of the car. It was they weren't excited about it, but it worked well, and so we were able to get it done. All right, the next question, honestly, this next one could be its own topic all onto itself, and that's around mental health support. I think we've had a lot of conversations on the council about the mental health challenges that are being experienced on all levels. Within the clinical framework, we've heard reports from a number of our providers. I've spoken to Maria Gomez about this at the Mary Center, just the level of despair that they're seeing from patients is very alarming. And I'll also say too, she has also said, and I know others providers have felt the same way, that the providers themselves are feeling the strain and the stress and feeling overwhelmed, putting their families at risk, going to the clinics every day, seeing the tsunami of challenges that these families bring. I think the average 311 call has gone up more than 500% in terms of the duration of the call because of how many issues that residents are bringing with them when trying to receive services. This is just more broad, but I assume you're seeing the same thing. And are there steps that the clinics have taken, or Dr. Gales, that you recommend we look at moving forward to address some of those holistic issues? Because although we are trying to address the direct medical needs of patients, if they're not sleeping, if the anxiety and the stress is only adding and exasperating the medical conditions that they bring forward and present to clinicians. So any general thoughts on what you're seeing and maybe some solutions moving forward?
Well, I hate to use the term that has been coined and associated with me, it seems, but I think to level set the conversation related to behavioral health, I think it's unfortunately shown that we have a significant crisis related to behavioral health services and access to services that predated COVID. I know when we talk about it from a pediatric and adolescent standpoint, everybody's been here, our kids, general folks, those of us working on the response, everybody on this call. But for example, when we talk about children, we know that there is a dearth of meaningful inpatient and outpatient treatment services. And we know that kids are frequently, the emergency room becomes a place where kids with psychiatric issues or psych issues frequently spend their time because they have no place to send them in terms of inpatient facilities. And then it's tricky because there's a dearth of outpatient services available to that population. Now that has spilled over to the general public in terms of the level of resources we have available to triage those different things. Because this is really hard, and it's going to continue to be hard because we're going to continue to ask people to do things that we've never had to do before. And I know from, we're continuing to work with our colleagues in behavioral health and crisis services. I think it actually would be helpful to have their team actually talk more specifically about what they're doing. I don't want to, hijack what they're doing and talk more specifically about that. And I know within the Montgomery Care space, the different resources with the behavioral health arm have leveraged, using NAMI as well as our colleagues at Georgetown to be able to provide additional support. This one's not easy because we're going to have to come up with strategies to pull from an already strained, limited network. And I think it's going to take some creativity in terms of how we think about and provide those services. As we move forward, I don't have any easy answer other than to say I think everybody on the call has I won't say maximized because I'd like to think there's more to pull from a limited system, but have certainly strategically leveraged the resources that we do have available now to almost as maximum capacity. And I think it would be helpful to have colleagues from other spaces again to come in and talk about those strategies. I will say from the youth perspective, our part of getting the school health service, the health and wellness centers back up and running to some degree also affords the opportunity for programs like the Linkages to Learning program to be able to provide, they've historically provided services as well. And so we want to be able to get those types of services back up and running, even in a limited capacity, but spread throughout the community so that children can access those services as well.
Thank you, Dr. Gales. Ms. Graham?
I just wanted to add from a Montgomery Care specific standpoint that all Montgomery Care's clinics have behavioral health services. Not all are utilizing the Montgomery Care's behavioral health program, the collaborative care model, but all clinics do offer behavioral health services to their patients. We are seeing uptick in that. Telehealth has been a boon to this. People are willing and able to be served on their behavioral health needs for telehealth. So that's been a big pivot there. I think the two things that we're seeing as you've mentioned, Councilmember Albornoz, is that when you're doing behavioral health work, it reveals the underlying socioeconomic needs, the social determinant needs. So there's a lot more time needed and needs for dealing with those and connecting people to resources and services. And then the second is psychiatry within behavioral health has been underfunded for a number of years. And this is exacerbating that need for psychiatric services. We have had a few situations of people having psychoses emerge while they're in lockdown or being less socially able to interact with others. And I think you mentioned it before, sort of the resources at adult behavioral health also have been constrained for a number of years, and being able to get appointments and create that linkage is sometimes difficult.
So Ms. McMillan, maybe we can do a follow-up. We all enjoyed our interview with Dr. Orlando Santiago the other day. I'm sure he will be appointed soon. And maybe once he is, we can give him time to get his bearings straight, but not too much time, and then come together again on this particular topic. The next topic is Care for Kids. And again, just such an important program. It's critically important that the residents know that we reaffirm that we will not turn any child down for this program. It continues to be a significant priority, particularly now, and the council and the executive will be notified in advance of any additional funding that will be needed. We would love to hear how it's going, what you're seeing, what we need to do, if we need to expand the services to address the immediate needs before us and the ones that are on the horizon. So, and specifically, if we can talk about the status of school-based health centers to serve Care for Kids. You touched on this, Dr. Gales, and we're so fortunate that Councilmember Rice, who is the chair of our Education and Culture Committee, happens to be on the HHS committee. And I know he and his colleagues on the Education and Culture Committee have been tremendous leaders in ensuring that the mental health needs and general needs of students have been met throughout the pandemic. And in fact, I'm going to turn to you, Councilmember Rice. I'm putting you on the spot if you'd like to make some opening comments about this. Oh, Dr. Gales, go ahead.
I would ask one thing. I know Dr. Boyce unfortunately has to step off at 11:30, so I was wondering if we could potentially move the dental conversation while we have her, and then come back to school health, if that's possible.
Let's do that. Absolutely. Good call. So the last round of questions before we go back to Care for Kids is specifically on dental clinics. And Dr. Boyce, thank you so much. We enjoyed meeting you last year, and it does feel like a generation ago the last time we spoke. But can you talk a little bit about what more specifically we're seeing at the dental clinics? Has there been a reluctance of patients coming through the doors? What infrastructure do we have in place? What are the modifications you've had to make? And we're also interested in how things specifically are going with services for children through the pandemic, specifically related to dental. And then what the schedule looks like right now for our clinics. So a lot to unpack there, but Dr. Boyce, if you could talk to us about where things are.
Sure, thank you. And I have to apologize, my computer camera is not working right now, so you'll just hear my voice. We were really focusing at the beginning of the pandemic to get the infrastructure needed to make our clinics safe for our staff and clients. As you know, we generate a lot of aerosols in all the procedures we do. So we have, and our focus initially was on Rockville. Rockville is our largest clinic, and it's where all our specialties are seen. So Rockville is almost completed. We've purchased HEPA filters. Our upper area UVGI systems are all in place. They already had upgraded to a MERV 13 filter, and the last step is actually putting a UV filter in the HVAC system. This protects not just inside the clinic, but your administrative workers and the other adjacent offices that are on the same air handle. So we've really taken everything into account. Our staff feel most of our staff are very pleased with everything that we've put in place. We have seen some challenges as far as bringing back staff, because even though we've put all these things in place, we do have staff who may have other medical conditions that put them at high risk. So that has been a little bit of an issue, but we are working with the county and getting other temporary staff to fill in some of those positions. So that has also affected us in opening up our other clinics. Now, as far as the infrastructure for the remaining clinics, that is also in progress. We still have opened them up, but we have them at limited services just because all the infrastructure is not in place. But everything's open except for one, downtown Silver Spring. So we can still see patients, but any major work, we're funneling all patients to Rockville since that is the most complete. One of our big priorities has been children. Again, we've added a pediatric dentist. He is actually the pediatric clinical director at University of Maryland, and he has worked in the past and for many years in community health settings. And he has been a great addition to the team. And we also have an oral consultant working with us, oral health consultant, working with us too, who also has a lot of community health dentistry experience. So we've been working on a new model to address our pediatric population. It's caries prevention and caries management. Procedures that can be done during the pandemic to help stabilize children throughout this whole time. And we're involving, teaching our dental hygienists and general dentists that there are things that you can do that, that are not outside of, general dentistry to help address this population. It's funny, as we started opening up more pediatric appointments, one of the challenges we're running into is parents hesitant to bring their kids in because they didn't want to take them away from virtual school. But we've really been going with a campaign on that. We've been addressing, we've pulled all the lists of our patients that had been canceled during the pandemic. And I'm actively having our staff just calling. And so our pediatric appointments are starting to increase. We've been working with Care for Kids, trying to get their patients in, specific patients that they need to have scheduled. So we're definitely seeing an increase in appointments. One of the other challenging groups has been the seniors. It's interesting. I've seen two different sides of the coin. One where seniors are hesitant to come in, which I totally understand. They're in the high risk group. Then I also have adult daycares where the seniors want to come in and they want to get their teeth cleaned. So I'm trying to manage and navigate a balance here. We have been actively talking about how we're going to address this. In fact, we were just talking about it yesterday. Teledentistry is one, but as Mr. Rice expressed, it's difficult with this senior population, which is something that we've encountered. We even had issues with the system as we were testing it out a month or two ago, navigating through our Microsoft Teams. But HHS is moving towards a system that I think will be really user-friendly and be much easier. But part of what we're trying to do is partner with the daycares where we are actually having somebody on site to help navigate those senior clients through this, what would be a teledentistry appointment. So there is a point person. This may be difficult for them to do it, but I think that'll be much easier. It's something we'd like to even explore with the school-based health center where there's a nurse that's actually navigating a teledental appointment, taking images or sending them back and making it much easier. We see teledentistry use as more of a screening tool, especially to our high-risk groups, the seniors. We want to limit the unnecessary appointments and as much information as we can get ahead of time. Medical clearances, things like that would be great. So when they come in, they're getting treatment done and being able to leave. So we're working through that. I'm trying to think. Oh, we've also added an oral surgeon. But again, sometimes it's a balance. Some patients are willing to come in, some are not. And I understand. But again, it's the same thing even with the staff. So these are some of the challenges COVID has presented, but we are definitely working on providing more available appointments to the citizens of Montgomery County.
That is super helpful, Dr. Boyce, and I appreciate your leadership through the pandemic. Just a couple of follow-up questions.
Sure.
You mentioned working on having temporary staff come in, which I really appreciate, and the creative thinking there. Do you have a sense of how sustainable that is? And do you feel comfortable with the current staffing plan to get us through the next several months? And if there is another spike in cases, how are we, if we can, how are we preparing for that?
So I think pre-pandemic, we were basically, I would say, on the brink of being short-staffed anyways. And so I think this will help with long-term solutions, having a steady temporary staff pool that we can pull from in the event. It's a big operation. My predecessors set up a really big dental operation with many clinics, many staff involved. When somebody calls out for whatever reason, it can really, change the dynamics of care. And so I think it's a good idea anyways to have some temporary staff. I actually have, I've had some referrals from other nonprofits who actually want to come and help work with us. So it would be great to have them here. And I think long-term, talking with the county in a meeting this past month, it's something that we could sustain. And what was your second question? I'm sorry. There was.
No, I think you nailed it. I wanted to follow up on something that Dr. Gale said earlier.
Mm-hmm.
And I want to highlight because it is so important. And we had seen evidence even prior to COVID
Mm-hmm.
that some of the members of our community were not engaging in government services or public health services
Right.
for fear that accessing those services may or may not impact their immigration status.
Right.
And I know that your team had been working on some cultural service training to make sure that the clinics were as well equipped as they could be prior to COVID
Mm-hmm.
to address those unique concerns. Because for better or worse, there are members of our community that don't place the same emphasis on dental services as they do medical services, which is incorrect.
Yes.
But it may be something they're more likely to let go if there's concern about whether or not their information is going to be shared or if there's a confidentiality issue. If you could talk a little bit about some of the updates on your efforts to increase outreach and customer service so that everyone feels comfortable and knows that their information is going to be private and that we have, when we can, bilingual speakers. If you can talk a little bit about those efforts, that'd be great.
So one thing moving forward and that I started last year is I wanted to make a more concerted effort to have more bilingual staff and not even just support staff, but actual providers there. So I think it's important when a patient can talk this, has somebody who can speak the same language with them. I think there's a trust that can be built. And so I've made a very concerted effort to try and bring in more bilingual dental providers. And so we've brought in one staff. I have another one that I'm in the process of bringing in, and I think that makes a huge difference. I have also been really working with even the newly supporting staff that have been hired, training them and helping them to understand that this is a service. You need to make you're represented in your community as you work here, and that we need to be welcoming. And I think the new staff that we've brought in, I really believe they have embraced that. And that's something huge. Now, the other piece that I was trying to work on, we were really trying to work on getting into the community. Prior to COVID hitting, we were really setting up appointments with the schools to do health fairs and just get down in there. Now that has paused, obviously. But I do want to do more work, hopefully with MCPS, so we can get on the community level to start building a trust with parents that we are here to serve and that this is a trusted, there is a level of trust to be built in that there will be privacy. Nothing will be shared. Doing community work is something that is huge for me, and we do want to get on the ground. And I'm hoping especially once the school-based health centers can get back in there, we can get in there too. We've been working in other areas with the school nurses, and we have developed a great relationship, and I hope that continues because that's how we're going to get on that level. The school nurses are in there. Our staff needs to be in there getting on the ground. I call boots on the ground, and I still am trying to do it.
Great. Final question, Dr. Boyce, for me. I know the Silver Spring Clinic was closed and we're referring folks to Rockville. How is that going? Is there any concern that with that closure we may be missing people? Are people transitioning over to Rockville?
Yes, so that is something that I had actually tasked somebody on that just last week because we're trying to make a concerted effort to contact the people that have been canceled, whose appointments were canceled actually prior to COVID, to try and get them scheduled to let them know, that we are still here for you. We do have Dennis Avenue that is open, which is a closer location so that people can still be seen there. But I would like to open Silver Spring as soon as possible because that is a concern as far as transportation. That is transportation all the way up to Rockville. It's hard. So that we are keeping an eye on that for sure.
Okay, and anything we can do as a committee to help, whether it's a resource issue, or et cetera, just don't hesitate. We agree with you that it is important to have as many hands on deck as possible, especially now.
Okay.
Well, I don't see any questions from my colleagues, so Dr. Boyce. Councilmember Rice.
Hey, so thank you very much, Dr. Boyce. And I really wanted to follow up on your partnership with MCPS, and it's something we can certainly continue to follow up with as our schools continue to potentially reopen and strategically about where those are and where those are placed. But I did want to talk a little bit about our regional hubs and put that out there as another opportunity for us to do some of that walking through the telemedicine aspect. Our regional hubs that have changed from food distribution to COVID kits to now everything under the sun, and also getting people signed up for services would be a great place to also have folks to be able to assist in walking people through. There are a lot of volunteers that are there, and quite frankly, just doing something along that line doesn't require as much of a skill set, and so could certainly be there to help a person say, how do you connect, making sure that you're connected, and then you go off into a private area, because obviously we don't want to have, private information disclosed about a client and their doctor or their dentist. But, from that perspective, you can still assist them a certain part of the way. And so we've done a really great job, DHHS, as well as the community, in standing up these regional hubs. And so that's another opportunity for us to certainly work with our volunteers and with you to really connect our communities to a lot of these services that you guys are providing.
All right. Well, I will definitely follow up with you guys on these suggestions. I definitely will. I'll be contacting you guys.
Excellent. Thank you, Mr. Chair.
Thank you very much. And why don't we go back then to our Care for Kids conversation. And Councilmember Rice, why don't you kick us off with some...
Back on again. You guys just can't get enough of me now. Trust me, I know it's the exact opposite. So I'm going to be brief here. Look, everyone knows the challenges that our children are facing when it comes to being disconnected from schools, disconnected from their friends, disconnected from their teachers. And that's one of the things that I think a lot of folks forget. A lot of our students actually really love their teachers, and they really serve as a mentor for them, oftentimes a second mother or father to a lot of these children, and really just a person, a sounding board that they can also talk to in a case where they may not feel comfortable talking to their parents about something. All of those things are instances that any teacher will tell you they've had the experience of having. And so disconnecting students from that really does make it challenging. And it really is one where then you couple that with the racial unrest that we have here in this country and this global pandemic. And all of that weighs on our children's minds every single day. It is striking that the last question that was asked at the vice presidential debate last night was from a child. And the child was talking about how the discourse in America is affecting her. That should be a lightning rod for us in terms of the need for us to try and fix this, to make sure we're providing support for our kids, making sure that they understand that they're safe, making sure that the United States is not broken, that we can coexist together, and that we need to showcase that we can be leaders that make sure that they have faith in our community and our society. And all of that goes directly to the mental health of someone. If someone feels as though their community is destabilized, if they feel as though people hate each other, if they feel as though there's no future, those are all things that feed a lot of the mental illness that people struggle with every single day. And so from that perspective, understanding that this is what's weighing on our children's minds right now says and creates an impetus for us to really do something and step up beyond where we've been. And so I really want to thank the county executive for his support, but really want to thank you, Chair Albornoz, and all of my colleagues on the council who continue to support the initiatives that are out there for standing up mental health for our children. And it's one of the things where you can never do enough. There will always be greater need that continues to exist. And so we'll continue to fight this uphill battle. But it doesn't mean that just because it's uphill that we quit. And so we've got to keep pushing. And so I just really want to thank, again, all the folks who have dedicated themselves to doing this, and to Dr. Santiago, who we will confirm shortly. I know my conversation with him had been tremendous in terms of his focus on especially our youth when it comes to mental health. And so look forward to some of the great things that he's going to be doing as well. So thank you very much, Mr. Chair.
Thank you, Councilmember Rice. And I guess the news obviously has been sobering, and we have seen a substantial increase in both newly enrolled. We're up 57% in accessing care for kids, and enrolled, which is up 16% over previous FY20 and FY19 numbers. And I guess my first question is, we continue to see those trends, correct? They are all still ticking upwards, or has there been a plateau of any kind since the beginning of the pandemic? Those numbers are all going up, I assume. And in terms of the status of our school-based health centers, you touched on this, Dr. Gales, but if you could expand on what the plan is, both in the short term and as we do begin to reopen schools, how we envision reimagining those school health centers. Are they going to be a lead in terms of helping schools in checking temperatures? How do we envision infusing them as we look at carefully and cautiously reopening schools?
So we've requested, as I mentioned, we've requested access to two of the school-based health centers, in particular two of the high school wellness centers, Gaithersburg and Wheaton. And due to the pandemic, all of the school-based health centers closed in late March 2020. We currently have 1,000, just shy of 1,300 children assigned to school-based health and wellness centers for their Care for Kids care. And even with those 2 sites open, we know that we won't be able to provide, medical services at the same level that we did before the pandemic. That said, we are looking to leverage those 2 sites to be able to provide some continuity of care and services, to leverage both in-person opportunities as well as going back to our conversation from the beginning of this session, talking about how we can use telemedicine to provide some additional support. But utilizing the inpatient visits for, physicals, exams, and immunizations and those types of things. Currently, we have 2 contracted school-based health and wellness center healthcare provider groups who are reaching out by phone to all of the Care for Kid patients enrolled to evaluate their health needs, provide any chronic care management for any of the children with those conditions, medication management, and also identifying and addressing any of those other salient social support needs that they may have. And again, we are continuing to look at how we can leverage telehealth to provide additional delivery of those types of services. And the remaining Care for Kids community providers continue to deliver their services in their respective spaces in person as well as via telehealth.
Thank you. And you answered 2 questions there in one, because the next question was specifically about telehealth. So I appreciate that. The final question that I've got is there was in the letter sent by PCC, MCAB, and HCLC a request for $129,000 and change for a client services specialist and a medical assistant. The medical assistant would support the RN case manager. Has DHHS had an opportunity to review that request, and do they agree with that need?
Yes, DHHS supports those 2 positions. Since FY14, there's been approximately a 46% increase in the patient volume between the overall patient volume without any, subsequent change in staffing. And additionally, the caseload for coordination has increased by approximately 54% since FY14. Given the increasingly complex needs of the children enrolled in the program. So to meet those increased need concerns as well as improve and enhance client care coordination and case management, we would support an increase in the contractual clinical staffing.
Perfect. So Leslie, that's good news. We'll follow up on that. So one follow-up point to a point you made earlier, Dr. Gales, and again with my esteemed colleague who's the chair of Education and Culture Committee here, would it be helpful for Councilmember Rice or the HHS committee to follow up with MCPS to see how we might be able to gain access to those 2 schools? Or do you feel that you've got it covered in your conversations with them? Would it be helpful at all for us to do that?
I think we're okay. We've been working closely with MCPS on a host of issues from the beginning. So I think, we've been able to, secure utilizing the different spaces for immunization program, for example, Rocking Horse. And so the teams are working on that. So I feel like we're in a good place because it also fits consistent with, potential plans where they also, in the absence of, bringing everyone back to school, any type of program that they would put together, they recognize the reality of probably the advantage of consolidating resources into, limited spaces to provide those services. So if something changes within that, we'll be happy to reach out, but I think we're okay for now.
Okay, terrific. Well, that covers the packet. This has been, go ahead, Councilmember Rice.
So along those lines, Dr. Gales, MCPS owns a lot of facilities throughout the county outside of school buildings. And so from the perspective of not, contaminating school buildings by having other functions that are there, there certainly are other properties throughout that we might be able to utilize as well. And so from that perspective, certainly keep us apprised, please, of the conversations that are going on. And I'll make sure that in my conversations with Dr. Smith and with Ms. Evans, that I certainly push for us to be very creative and outside of the box in terms of our thinking of how we can be collaborative in this effort. I mean, obviously, when we have folks that are food insecure, we have folks that are going to be healthcare insecure as well. And so from that perspective, that's the reason why we're seeing the increase. It's a no-brainer. I mean, people are losing their jobs. 800 people at Marriott, our largest corporation here in the county in terms of employment outside of Montgomery County government, laid off 800 folks. Those are 800 folks who no longer have a job. Now, sure, they have COBRA coverage. I've been through this before. I used to work for Marriott, but COBRA is incredibly expensive to try and retain your coverage. And so from that perspective, folks find themselves in a lurch, especially with kids. And so from that perspective, I think that's where it's coming from. Regal Cinemas shutting down. And let's just not pretend, right, that doesn't have an impact on our residents and people who were employed. And some of them had their healthcare coverage through these companies. And so they're losing their healthcare coverage every single day. And that's why we're seeing more and more people who are signing up to protect their children and protect themselves. But mainly their focus is now on their kids and just ensuring that they can get the vaccinations, that they can get, the checkups that they need to. So this is going to be something that I think, unfortunately, until our economy starts to recover, we'll continue to see those increases, which is why we're going to have to be very creative in terms of the ways we're addressing this, which means partnering with organizations like MCPS and others to really get out there into the community and make things more accessible for them. So I appreciate, Mr. Chair, everything that you've said. I've heard it loud and clear. I'll make sure that I reach out to MCPS as well. And Dr. Gales, please keep us posted on the status.
Will do.
Thank you. I was about to say Dr. Rice. Thank you, Councilmember Rice.
Hey,
didn't go through that much school. Can't do it.
Councilmember Glass.
Yeah, just to close out this really important conversation, we're all looking towards November 3rd, right? And I got to hope, and I know we all hope, that some more aid, financial assistance is going to come to municipalities and states, because this is all tied together. And we just got to vote. And we got to hope that our national leaders do the right thing and support all of the work that we're doing here to keep everybody healthy and safe. I would say that the information in total that was provided today is the canary in the coal mine, but we've known this. We've been looking down this mine shaft for months, and we just need the resources to put everybody on a better footing and make sure everybody is safe. And so, again, just in summary, thank you everybody for what you're doing. We know how hard this work is, particularly today, as if it wasn't hard 1 year ago. Last time we had a similar update, but we are all looking 10 miles down the road on Pennsylvania Avenue. And hopefully change is coming so that we can get the resources we need to keep everybody safe. So thank you.
Well said by both of my colleagues. There's a few follow-up items that we were tracking throughout through the discussion. I do have one final thought, and I had spoken to Dr. Crowell about this and promised I would hold off because the HHS has so much going on right now. But I think that there is an opportunity for us to have a health summit to discuss those disparities in health and talk about some of the lessons learned through COVID. And I think the rollout of the health equity report, Dr. Gales, would be the perfect construct for us to have that discussion, have that be a presentation followed by panel discussions with the objective of coming out of there with specific policy recommendations and budget recommendations going into FY22 that we can all lean on and that we'll all need moving forward. So I'll follow up with you. That I don't think the dust is ever going to settle, but when it settles a little bit more, I'm envisioning January or February for something like that. But would want to work collaboratively with your team to get it off the ground. So thank you all so much. This has been a very informative and productive session. And thank you all, and everybody enjoy your lunch. Take care.
Stay safe, everybody.
It's important to to recognize the contributions of our election workers.
I'm glad to hear that, because that's something that young people, back again in our day, that was something